Imagine going to a doctor for chronic, really debilitating intimacy pain, and their proposed solution involves, of all things, extracting the DNA of male salmon.
I know, it sounds totally made up.
It really does. I mean, they purify it in a lab and then inject it directly into your most sensitive, intimate tissues. It sounds like science fiction or like some bizarre internet rumor.
Oh, absolutely. But it is actually grounded in some very real, very cutting-edge science.
Yeah, and today we are looking at a huge stack of clinical sources. We've got medical studies, aesthetic clinic protocols, and gynecological reviews that prove this isn't just real, it is literally the bleeding edge of women's sexual wellness.
It really is a fascinating shift in the medical field.
Right. So welcome to the Deep Dive. I'm so glad you're joining us today because we are tackling a subject that honestly usually gets whispered about or just completely hidden away: female intimate health.
Yeah, it's a topic that deserves so much more open discussion.
Exactly. Specifically, we are looking at the clinical approach for combining intimate polynucleotide biostimulation with something called G-spot hyaluronic acid augmentation.
And it is a remarkable convergence of disciplines, really, because for a long time we've associated aesthetic and regenerative medicine purely with the face.
Right, like smoothing out wrinkles or, restoring volume to the cheeks.
Exactly. But clinicians are now taking those exact same regenerative principles and applying them to the vaginal anatomy. And the goal here is not merely cosmetic.
Right.
This is about revolutionizing function and treating severe chronic conditions like vulvovaginal atrophy that cause just immense physical pain.
That is the part that completely blows my mind. I mean, we are taking tools designed to make skin look younger and using them to physically restore lost biological function.
It's incredible, yeah.
But to understand how these treatments actually work together, we really need to map out the anatomy first. So, okay, let's unpack this. The infamous elusive G-spot.
Ah, yes, the historical debate.
Right, because historically there has been this massive debate over whether this thing even physically exists, right? I mean, it was named after Ernst Grafenberg, a German physician who wrote about it back in the 1950s. But for decades, it was considered by a large chunk of the medical community to just be a complete myth.
Well, what's fascinating here is that the concrete anatomical proof actually arrived relatively recently. You have to look at the work of Dr. Ostrozensky, which is detailed right in our sources.
Okay.
So, to finally settle this debate, he conducted a highly specific anatomical study. He performed a meticulous dissection on the cadaver of an 83-year-old woman.
Wow. An 83-year-old cadaver.
Yeah. And he discovered this distinct physical structure buried deep in the anterior or front wall of the vagina. He actually described finding a blue grape-like structure.
A blue grape-like structure. That's such a wildly specific image.
It really paints a vivid picture, doesn't it? But crucially, he noted that this structure resembled erectile tissue. Yeah, biologically, it's very similar to what is found in male anatomy. So we are talking about a localized cluster of tissue that is highly vascular, incredibly nerve-rich, and entirely capable of engorging and swelling during sexual stimulation.
That is amazing. So the debate is just largely over then. It is a vascular anatomical reality.
Exactly. It's real.
But actually finding it in a clinical or, an intimate setting is famously difficult. It's not like there's a bright red target painted on the tissue.
No, definitely not.
And our sources include some surprisingly practical clinical advice for locating it. The instruction is basically for a woman to insert her index finger and make a come here motion pointing upward toward the belly button.
Right, that's the classic technique.
Yeah, and you aren't feeling for like a perfectly defined little button. You are feeling for a rougher, somewhat ridged region of tissue. And interestingly, when it's stimulated, it often triggers a sudden sensation of wanting to pee.
And that sensation is a key anatomical marker, actually, because of its close proximity to the urethra. Now, the challenge is that this grape-like structure sits deep within what we call the submucosal layer.
Right, and just to clarify for everyone listening, what does submucosal actually mean in this specific context?
Sure. So think of the vaginal wall in layers. The top layer, the mucosa, is the moist inner lining that you can actually touch.
Okay.
The submucosal layer is the connective tissue sitting directly beneath that lining. Because the G-spot is buried down in that deeper layer, many women find that achieving the right angle or getting enough physical pressure during intimacy to adequately stimulate that erectile tissue is mechanically very difficult.
Which brings us directly to the first half of the clinical protocol in our stack of research, the G-spot augmentation, which is widely known as the G-shot.
Right.
So if finding it and stimulating it is that hard mechanically, how does a clinician actually fix that?
They alter the topography, and they do this using hyaluronic acid, or HA, but they don't just use any HA, they use a cross-linked HA filler.
Cross-linked. How exactly does that change the behavior of the acid?
Well, standard hyaluronic acid is quite runny. It's great for moisturizing the skin. But cross-linking is a chemical process that essentially binds the HA molecules together, turning it into a much thicker, more structurally rigid gel.
Oh, I see.
Yeah. So the clinician injects a very small amount of this firm gel, usually just about 2 to 4 milliliters, directly into that deeper submucosal layer we just talked about.
Wow, just a tiny amount.
Very tiny, just about 3 to 5 millimeters deep into the anterior vaginal wall.
So it's acting almost like a physical cushion.
Hmm.
I kept thinking of it like placing a plump, firm throw pillow underneath the fabric of a flat couch.
That's a great way to look at it.
Yeah, by adding that targeted volume underneath, you are instantly changing the shape of the room, right? You make that specific target so much easier to just physically bump into.
That throw pillow analogy illustrates the mechanics perfectly. You are physically projecting that specific area further out into the vaginal canal. In fact, one of the clinical sources describes the resulting augmented bump as being about the size of a Singapore 20-cent coin in diameter.
Oh, that's really specific.
Yeah, it increases the localized friction and accessibility during intimacy. The injection itself actually takes only a few seconds to perform under local anesthesia.
And how long does that pillow last?
Well, because the body slowly metabolizes HA over time, the structural effects can last anywhere from 4 to 6 months or even up to 12 to 18 months, depending on the specific filler density and, the patient's own metabolism.
Yeah, and this is totally reversible, right?
Mm-hmm.
I imagine if someone gets this done and finds the new sensation uncomfortable, they wouldn't want to be stuck with it for over a year.
Yes, and that is a critical safety feature. Hyaluronic acid is a naturally occurring substance in the human body. So if a patient experiences any discomfort or simply doesn't like the result, it's not permanent.
They can just get rid of it.
Exactly. The clinician can inject a specific enzyme called hyaluronidase. That enzyme acts like a chemical key that instantly dissolves the cross-linked HA filler.
What, instantly?
Pretty much, it returns the anatomy completely to its original state within hours.
That is wild. Okay, so we have our structural throw pillow. The G-shot provides this immediate mechanical bump. But if we stick with that living room metaphor, a brand new throw pillow doesn't really do you any good if the fabric on the couch is tearing, or if the floorboards beneath you are literally dry rotting.
Exactly.
Because the G-shot alone doesn't do anything to address the underlying cellular health, the lack of hydration, or the age-related thinning of the surrounding vaginal tissue, right?
You've hit on the exact limitation of early aesthetic gynecology right there.
Yeah.
The G-shot addresses the mechanics of physical stimulation, sure, but it completely ignores tissue degradation. And to understand why that is such a massive problem, we really have to look at the biological reality for women navigating menopause.
Or women who have experienced chemically induced menopause from things like cancer treatments, right? Like chemoradiotherapy.
Right. So, if we connect this to the bigger picture, what is actually happening to that tissue when a woman goes through menopause?
Let me guess. It all comes down to estrogen.
You got it. The defining factor is a drastic drop in estrogen. Estrogen is essentially the hormone that keeps vaginal tissue thick, elastic, and, well supplied with blood.
Okay.
When estrogen plummets, women often develop a condition known as genitourinary syndrome of menopause, or GSM, with a specific focus on vulvovaginal atrophy.
And the lived reality of this is just severe. The sources note that the mucosal lining becomes incredibly thin, pale, and fragile. The collagen fibers literally fuse together.
Yeah, they do.
The elastic fibers fragment and break, and the local blood flow just slows to an absolute crawl.
It leads to chronic, low-grade inflammation. We are talking about severe dryness, relentless itching, micro-tearing of the tissue, and dyspareunia, which is intensely painful intercourse. It basically feels like sandpaper.
That sounds agonizing.
It is. And the statistics in the clinical reviews show this affects at least half of all postmenopausal women.
Half. Wow.
Yeah. Yet, a staggering number of women just suffer in silence. They just believe that this intense discomfort is an unavoidable penalty of getting older.
Well, here's where it gets really interesting. Because to fix that decaying cellular environment, the clinicians aren't just prescribing estrogen creams anymore.
No, they're not.
They are introducing a second foundational element to the protocol, which is polynucleotide biostimulation. And the source of this highly purified DNA, it is extracted from the gonads and sperm of male salmon and trout.
I know, I know. The immediate reaction to that is usually absolute disbelief,
Oh, yeah.
but the biochemistry behind this is incredibly sound.
Okay, but I have to push back here on behalf of literally everyone listening. Why fish sperm? Of all the biological materials on Earth, why are we injecting salmon DNA into the human vaginal wall to repair tissue?
It's a fair question. It mostly comes down to biological compatibility and abundance.
Okay.
The DNA found in the gonads of trout and salmon is surprisingly highly compatible with human DNA. Furthermore, the extraction process uses this highly purified technology.
Which does what exactly?
Well, they strip away all the active proteins, all the fats, all the biological contaminants that could trigger an allergic reaction or an immune response in a human.
So it's heavily filtered.
Exactly. What you are left with isn't, fish fluid. It is simply raw, universal biological building blocks. Just pure nitrogen bases, nucleosides, and nucleotides.
So they're literally just delivering the raw materials that human cells need to rebuild themselves.
Correct. When injected, these polynucleotides act almost like a biological fertilizer. They don't provide immediate volume like the HA throw pillow we talked about.
Right.
Instead, they progressively break down and stimulate the local fibroblasts.
Okay, wait, let me see if I have this right. Fibroblasts are basically the cellular factories responsible for maintaining the structural framework of our tissues, right?
Right.
So if the fibroblast is like a factory assembly line, what exactly is the salmon DNA doing?
Well, in an aging or estrogen-deprived environment, that fibroblast factory has essentially shut its doors. The workers are gone, there are no materials left to build with.
Oh, that makes sense.
When you inject the polynucleotides, you are basically backing up a fleet of delivery trucks to the factory and unloading tons of fresh bricks and steel the nitrogen bases.
The building blocks.
Exactly. The factory absorbs these materials and suddenly powers back up. It naturally begins producing new type of collagen, new elastin fibers, and fresh extracellular matrix.
Wow.
You are biologically turning back the clock on the tissue itself.
And that directly reverses the vulvovaginal atrophy we talked about earlier.
Yeah.
The tissue gets thicker and much more elastic again. But the sources also mention that polynucleotides are heavily involved in moisturizing.
Yes, they are.
If I remember correctly, they organize into a 3D gel that binds massive amounts of water.
They are highly hydrophilic, meaning they attract and hold water. This provides intense moisturizing from the inside out, while simultaneously reducing that chronic inflammation.
Wait, let me challenge that for a second. We just established that hyaluronic acid is famous for being a super hydrator. If the HA we use for the G-shot already hydrates the area, why do we need to inject the salmon DNA at all? Why not just flood the entire area with HA and just call it a day?
That is a great point, and it raises an important question about cellular synergy.
Okay.
HA does provide excellent hydration, yes. But hydration alone doesn't force an aging, dormant fibroblast factory to suddenly start building new collagen. HA is just water.
Right.
However, hydration is an absolute prerequisite for fibroblast vitality. A dry fibroblast cannot function no matter how much DNA building block material you dump onto its loading dock.
Okay. So the factory needs the lights and the water turned on before the workers can actually use the bricks.
You nailed it. And the clinical data backs that up entirely. The hyaluronic acid creates the perfect, optimal, watery environment. It preps the soil, basically.
I see.
Once the environment is properly hydrated by the HA, the polynucleotides can step in and actually execute the deep cellular repair work. There are two completely different tools doing two different jobs that fundamentally rely on each other.
That makes a lot of sense. So we have our two distinct components. We have the regenerative salmon DNA to rebuild the tissue from the ground up.
Yep.
And we have the thick, cross-linked HA to build our structural throw pillow for the G-spot. So if I'm a patient walking into a clinic, how does the doctor actually combine these? Like, what is the order of operations?
Well, the clinical protocol is meticulous. You can't just inject them both at the same time and hope for the best.
Right.
The sources lay out a sequential two-phase approach. They call it priming and consolidation.
Priming the canvas before you paint.
Exactly. The priming phase focuses exclusively on the polynucleotides. A clinician will typically start with a series of 3 sessions, spaced about 2 to 3 weeks apart.
Okay.
And they use a highly concentrated dose of the PNS. The sources cite 40 milligrams per 2 milliliters.
That sounds like a lot. What is the impact of that specific 40 milligram dosage?
It acts as a massive localized shock of biological fuel. It is specifically designed to aggressively kickstart tissues that literally haven't produced their own collagen in years.
Wow.
And to deliver this, the clinician uses a 30-gauge needle.
Oh, I know exactly what you listening right now are probably thinking. Needles down there. I really think we need to talk about that 30-gauge needle because that just sounds terrifying.
I know, it is completely normal to be afraid of that. It is the most common fear patients have. But for context, a 30-gauge needle is incredibly fine. It is roughly the thickness of a few strands of human hair.
Okay, that's really thin.
Very thin. And the clinical protocols prioritize patient comfort heavily. A customized 30% lidocaine cream, which, by the way, is a profoundly strong topical anesthetic, is applied to the entire intimate area for a full 30 minutes prior to the procedure.
So they don't really feel it.
Right. The area is so thoroughly numbed that patients typically only report feeling a sensation of dull pressure or a very mild, highly tolerable pinching.
Okay, assuming the area is completely numb, how is the doctor actually injecting this fuel into the tissue? Do they just jab it in?
No, they employ two very specific injection techniques depending on the anatomy. For the labia majora, the thicker outer lips, they use a linear retrograde technique.
What does that mean?
The clinician inserts the needle and slowly injects a continuous line of the PN fluid as they pull the needle back out.
Got it. Though I imagine you can't use that same sweeping, rigid line of fluid for the inner, much more delicate tissues. The anatomy there is completely different.
You're spot on, and that's exactly why the protocol shifts for the inner structures. For the labia minora and the very delicate vestibular areas around the vaginal opening, they switch to what's called a micro-wheel technique.
Wheel, spelled W-H-E-A-L, like a tiny hive.
Right. Because that inner skin is incredibly thin and fragile, it needs localized, very gentle absorption. The clinician essentially deposits tiny, superficial drops of the fluid just beneath the mucosa, spaced about half a centimeter apart.
Oh, I see.
Yeah, it looks almost like a grid of tiny mosquito bites that gently diffuse into the surrounding tissue over the next few hours.
Okay, so the patient goes through 3 of these priming sessions over, what, a month and a half? The DNA is in there, the fibroblasts are churning out fresh collagen, the tissue is plumping up, and the inflammation is dropping. What comes next?
Then we enter the consolidation phase. About 15 days after that final PN session, the tissue is healthy and ready.
Okay.
The patient returns, and the clinician brings in the hyaluronic acid. And this is where modern regenerative aesthetics gets very tailored. Clinicians will actually use different types of HA during this single visit to achieve different goals.
Which goes right back to our earlier distinction about runny versus rigid HA, right?
Exactly. The clinical protocols often utilize blended products for the overall area. For instance, the sources highlight a product called Nugen.
Nugen, okay.
Yeah, it premixes 20 milligrams of the salmon DNA with 20 milligrams of non-cross-linked, the runny hydrating HA. They use this to bathe the entire intimate area in deep hydration, basically turning the lights on for the fibroblasts one last time.
But for the G-spot itself.
For the G-spot, they put the blended stuff aside and bring out the thick, cross-linked HA.
The throw pillow.
The throw pillow. They target that very specific, grape-like anatomical cluster on the anterior wall to create that prominent structural prussian we talked about. So you have comprehensively repaired and hydrated the entire biological environment first, and then you mechanically enhance the specific target for pleasure.
So what does this all mean? Really, it represents a total paradigm shift in how the medical field treats female sexual wellness. For so long, medicine completely separated form and function.
Absolutely.
If a woman had pain, she was given a functional treatment. But if she wanted an aesthetic or sensory improvement, that was entirely separate and honestly often dismissed.
And this new protocol acknowledges that in female intimate health, those things simply cannot be separated. Tissue health, physical sensitivity, and psychological confidence are all deeply intertwined.
Yep.
You cannot have a successful mechanical enhancement if the underlying tissue is tearing and actively inflamed.
By using the salmon DNA, a woman isn't just getting a mechanical bump to try and force a sensation out of damaged tissue. She is actively reversing cellular aging.
Exactly.
She is curing the dryness, eliminating the sandpaper friction, and healing the pain at a foundational level, while simultaneously enhancing the physical anatomy.
It really is a profoundly validating area of modern medicine. It finally treats the root cause of the atrophy rather than just putting a Band-Aid over the symptoms.
Which brings us to the ultimate takeaway for you, our listener. Whether you are navigating the often difficult, silent waters of menopause, experiencing postpartum discomfort, recovering from medical treatments that impacted your hormones, or If you are simply deeply curious about the frontiers of sexual wellness, the message here is empowerment.
It absolutely is.
Medical science now offers non-surgical, non-hormonal, actively regenerative solutions. We are officially past the era where women have to accept intimacy, pain, severe dryness, or a loss of sensation as just some unavoidable penalty of natural aging. You just don't have to live with a crumbling foundation anymore.
The clinical evidence we've reviewed is incredibly clear. By addressing both the function, the cellular vitality of the tissue and the form, the physical prominence of the anatomy women can actually reclaim their comfort and their sexual confidence.
It really is incredible to see these two worlds of medicine merge like this. But before we wrap up this deep dive, I want to leave you with one final, slightly wild thought to mull over.
Right.
We just spent 20 minutes discussing how medical science has figured out how to harvest the DNA of male salmon, purify it, and inject it into the human body to successfully reverse cellular aging and restore intense nerve sensitivity in some of our most intimately complex tissues.
Right.
So the question is,
Yeah.
what's next? If we can biohack our cells to literally reverse time and cure chronic pain using targeted marine DNA today,
Oh.
what other highly specific deteriorating tissues in the human body are just waiting to be regenerated in the next decade?
The potential for regenerative DNA technology across the entire human body is truly just beginning to be unlocked.
It's definitely something to think about. Thank you so much for taking this deep dive with us. We'll catch you next time.